Okay, so the first one, from the congenital lung malformation. Then we have the next one, we covered the alveolar cell types. So here I told you that there is a type 1 and type 2. Two type of uh, two type of cells are present there, basically type 1 and type 2. Where the cuboidal cells are the type 2, they are basically having the secretory function, and they secrete the surfactant. The most important thing, type 2 secrete the surfactant. Now we have the next one, that is the neonatal respiratory distress syndrome. So in short, what happened that when baby born, and then the next one, what happened that for the respiration, for the to respiration with the room air, there should be there should be some sort of gaseous exchange. Okay, so that is completely depend that neonatal respiratory distress syndrome. Distress itself is there is a when baby have the stress, or there is distress when he or she is trying to ventilate. So basically in this concept, what happened that there is a surfactant deficiency, so which is you can say pneumocyte type 2 cells deficiency. If there is surfactant deficiency, that led to the increase in surface tension, and that led to the alveolar collapse, and it is like a ground glass appearance of the lung field. So you can see here, this is the ground glass appearance. So when deficiency of surfactant, or there you can see the maturation of the lungs properly, so increases in surface tension, so baby put more force to do the ventilation, and because of that there is alveolar collapse, and that led to the ground glassy appearance on the lung field. There is x-ray where ground glassy appearance, so you can see that look at this part, ground glassy appearance like this way. So it is a basically due to the surfactant deficiency. Now here the prematurity for this neonatal respiratory distress syndrome, the first one is a risk factor, that is a prematurity, diabetes during pregnancy, when the mother is having diabetes, and that is why there is due to the increase in fetal insulin, and or it can be due to the c-section delivery. That is why it led to the decrease in release of the fetal glucocorticoid, less stressful than the vaginal delivery. What are the treatment for the neonatal respiratory distress syndrome? The first one, maternal steroid before birth. So mother should be given maternal steroid before the birth, and exogenous surfactant for the baby. So basically treatment involved two level. One you can give to the mother, and another one we can give to the baby. Mother given steroid, and baby exogenous surfactant for the infants can be given. Now the therapeutic supplement of the O2 can result into the retinopathy of prematurity, intraventricular hemorrhage, bronchopulmonary dysplasia, RIP. So the O2 therapeutic supplemental O2 can result, means when you are providing therapeutic supplement of O2 oxygen, so that can result into the retinopathy of the prematurity to the baby, intraventricular hemorrhage in the brain, and bronchopulmonary dysplasia that can maybe cause. Now the screening test for the fetal lung abnormality is the most important here. The lecithin sphingomyelin ratio is calculated. Lecithin sphingomyelin ratio is in the amniotic fluid is calculated. It should be more than 2, so it is healthy. Less than 1.5, then it is suspect to the neonatal respiratory distress syndrome. And if there is a foam stability index, and surfactant albumin ratio is also given. So persistently low O2 tension, that is a high risk of the PDA. Now in this situation, what happened basically that lecithin and sphingomyelin ratio, you can see when it is less than, so here we can see that less than 1.5, so the whole this region can be belong, can we say that basically it is due to the when there is a baby is having the suspect of neonatal distress syndrome. Next one, when we talk about the respiratory anatomy, so we start from the adult again. So here in respiratory anatomy, there is a respiratory tree. the respiratory tree itself, it is divided into the two zone, conducting zone and respiratory zone. So in the conducting zone there is a large airway consists of the nose, pharynx. Yeah, it has a nose, pharynx, larynx, trachea and bronchi. Airway resistance highest in the large medium size bronchi. Airway resistance is the highest to the large to the medium size bronchi. A small airway consists of bronchioles that further divide into the terminal bronchioles. Large number of the pallor that increases the least airway resistance. Now, warm, humidified and filter air, but here does not participate in the gaseous exchange. The conducting zone, where we have the warm, humidified and filtered air is formed or processed, but it do not does not participate in the gaseous exchange, and that is what is known as the anatomically dead space. Now the cartilage and goblet cells extend to the interbronchi. Now pseudostratified ciliated columnar epithelial cells, pseudostratified ciliated columnar cells primarily make up of the epithelium of the bronchus and extend to the beginning of the terminal bronchioles. The transition of the cuboidal cells clear mucus debris from the lungs, mucociliary escalator. Now airway smooth muscle cells extend to the end of the terminal bronchioles and that led to the spar beyond this point. Now it is a terminal bronchiole. Now the second zone in the respiratory is a respiratory tree. It is a respiratory zone where really there is a gaseous exchange occur. Now the first one is here, lung parenchyma. Important principal cells consist of the respiratory bronchioles, alveolar duct and alveoli. Three important things, because most of the time you get confused with the only alveoli, but there is alveoli, alveolar duct and bronchiole. The three most important, three lung parenchyma cells, they are participate in the gas exchange and mostly cuboidal cells in the respiratory bronchioles, then simple squamous cells in the alveoli. Cilia terminate in the respiratory bronchioles and alveolar macrophages clear debris and participate in the immune response. Now for the figure representation, we can have the 2 point. There is a conducting zone here where trachea, bronchi and bronchiole. So we see that in the trachea part there is a goblet cells, basal cells, that basal cells and upper one there is a ciliated cell. So it is basically pseudostratified ciliated columnar epithelial cell, smooth muscles, and the lower one, the basement, we have the cartilage. In the bronchioles there is ciliated club cells, ciliated and club cells present. You can see here the club cells. I told you before that their club cells are the non-ciliated. They are the low columnar cells with the secretory granules and located in the bronchioles, degrade toxins via cytochrome P450, secrete component of the surfactant and progenitor cells for the club cells and ciliated cells. Now the next one here, that the terminal bronchioles. When you talk about the terminal bronchioles itself, it has the cuboidal cells, club cells again present here, and it is a simple ciliated cuboidal epithelial and line the basement, that is the smooth muscles. Now in the respiratory zone, there is respiratory bronchioles present, cuboidal cells, club cells and squamous cells, simple cuboidal squamous cells is fast present. The last one is alveolar sac. In the alveolar sac there is a two types of cell basically present, type 1 and type 2. Alveolar macrophages and capillaries are the accessory, they also present. Type 1, type 2 I told you before. Now when you talk about the lung anatomy, here first we cover respiratory anatomy. So we talk about the respiratory tree, conducting zone and respiratory zone. Now next one, it is lung anatomy, lung as a gross, when you talk about the whole lung. So it says that in lung anatomy there is a right lung has 3 lobes, left lung has a 2 lobe, and lingula homologue to the right middle lobe. Instead of the middle lobe, left lung has a space occupied by heart. Now relation of the pulmonary artery to the bronchus to each lung cilium is described by the Ralls. Right anterior, left superior. Carina is a posterior to the ascending aorta and anterior medial descending aorta. So basically it is the middle part. Here right lung has more common site. Right lung has more common site for inhaled foreign body object, and because of that this right main stem bronchus is wider and more vertical and shorter than the left. So we can have the right side is the most important. There is a more common side for the inhaled foreign body because the right main stem bronchus is wider, vertical, and shorter than the left one. Now let's talk about the condition when we aspirate the peanut. So while supine, so if the person is lying down like this, its nose, its eye, like this way, while supine, so usually enters the superior segment of the right lower lobe. Superior segment of the right lower lobe. I think it's given. Yeah, right lower lobe. Yeah, this one. So you can just correlate right lower lobe superior segment. So we can say it is something like this part, right side superior segment, something like this part. So when while lying on the right side, so when person is lying on the right side, so technically face will be like this and the body will be like this. So basically it is a right side, and while lying on the right side, so what will happen, that right is lower side and left is upper side. So there is a usually enter to the right upper lobe. So right upper lobe here, right upper lobe, this part, right upper lobe, see, which is the nearby. Then while upright usually enter right lower lobe, right lower lobe. While upright means person is standing or sitting, the situation. So we can say there is a right lower lobe, right lower lobe, right upper lobe, and right lower lobe. So most important thing, you can see right middle lobe is least affected. So in the question in the exam, most commonly right lower lobe is going to be the answer, and when the person is lying down on a bed, that situation, right upper lobe is supposed to be the most accurate answer. Now going to the next one, anterior and posterior aspects. So it's simple anatomy. Mid clavicular line, clavicles present. These are the clavicles, and there is a mid clavicular line. Then intercostal space 1. So here is a right upper lobe, intercostal space up to the 3. Horizontal fissure, right middle lobe, oblique fissure, and then right lower lobe. Then here we have the pleura. Then we have the lingula, left lower lobe, oblique fissure, left upper lobe, and mid clavicular line. Now going through the back side, so in the posterior view, in the back side, we left lower lobe and right lower lobe. That is why when you auscultate a patient having suspect of pneumonia, or when there is some sort of foreign body inhalation, that situation we prefer to check, we prefer to auscultate right when we prefer to auscultate front view. So in the frontal view, our target is basically this zone. We are able to hear some sort of obstructions or some sort of like ear damage, or in the back side we prefer to check on the this side, the both side. Most commonly right lower lobe get affected, and we can observe, we can auscultate the situation while going for the CT scan. So in the CT scan, this carina, if you remember that two trachea, when in the respiratory tree, when they divide, so the central part is a carina. You can see there is a small like thinning this part here. So this part, and basically lung having the air filled cavity, that is why it is blackish in color. Now the next one is diaphragm structure. When we talk about the diaphragm structures, the most important, the diaphragm structure itself, it is a perforating diaphragm structure, like those structures which perforate the diaphragm. So we talk about the first one at the T8 level. There is a inferior vena cava, T8 inferior vena cava, right phrenic nerve. At T10 there is esophagus, vagus, that is the like cranial nerve 10, and then there is at T12 there is aorta, that is a thoracic duct, while it has the azygous vein, blue in color, and there is a T so at T12 it is red, white, and blue. Mnemonics, very famous to learn this. So the I8 10x at 12. So here I stand for here 8, I8 means there is a 10 egg. So the here at inferior vena cava I T8, at T8 I8 10x, when at T10 10 eggs stand for the esophagus. X at 12 12 at A stand for aortic hiatus, so it is at 12. So C345 keeps the diaphragm alive, and other bifurcations, that is the common carotid bifurcations at C4, and the trachea bifurcates at the T4 level. So next one, that is diaphragm is inverted. C4 3 4 5 phrenic nerve, pain from the diaphragm, irritations, ear, blood and pus in the peritoneal cavity, and that can lead to the transfer to, shoulder to the trapezius ridge. So the next one, here we talk about that there is a respiration physiology.